UK, broadcasting around the world. You're listening to the Mic Drop Club, hosted by Douglas Hammond-Dishay. Message received. You do not need to know what you need. Just engage with the podcast feed. Providing weekly insights into cool stuff we've read, saw, did, or heard about what made us say, wow, eureka, damn, nothing is off limits. If it motivates and inspires you to reach your goals, then it shall be discussed. Featuring guest interviews from high performers and people of influence, and weekly awards for the best mic drop moment. This podcast is guaranteed to leave you pumped up for the week ahead. Don't just live life. Make life boom.
That's right, people. How you guys doing out there? Welcome to another episode of the Mic Drop Club with your host, Douglas Hammond-Dishay. Today is not an ordinary day. Today I'm going to cover a topic that's been very close to my heart when it comes to digital transformation. And that is all about the user experience. Taking a look at the behavioral changes that individual needs to reconcile, come to terms with when it comes to embracing technology. And as the music and as the intro would allude to, this is an international affair. So we'd like to share experiences with people all across the globe. So today I'm honored to have Dr. Gyles Morrison in the house to talk to you guys, to share a debate, a discussion, an interactive discussion all around clinical user experiences and around the health and digital transformation landscape. So with no further ado, Dr. Gyles Morrison, how are you doing? Welcome.
Hello. Thank you. It's a real pleasure to be here, Douglas. I think what you're doing here with the Mic Drop is great. And it's my pleasure to actually be a part of this movement. Thank you.
No, brilliant. In fact, the power of the whole LinkedIn has been phenomenal. It is the journey that keeps on giving. Literally, I'm connecting and having real insightful conversations with people all across the globe, particularly around digital transformation, motivation, inspiration, all that kind of stuff, because I am a firm believer that technology is an enabler, ultimately designed to liberate us from a process that was deemed antiquated, whether that's paper or whether that is just based upon the way we go about doing things in the not the most productive way. You know, I was challenged at a very young age to embrace critical thinking. So I always try to unpick things, you know, break things, find out what each part does, and then reassemble in a far more efficient way. My parents would argue against that. Obviously, the toys I broke as a kid. Yeah, so Gyles, it's all about you. This is all about you taking over the show, really, and let's have a conversation from a German perspective. So, in terms of the user experiencing around health, what's that journey been like, and how did you get in that field in the first place?
Yeah, so actually, I started out in London. I'm from East London, Tower Hamlets, born and raised, and for a long time, I was actually thinking I would go into art or writing, maybe be an illustrator when I was a young child. And I realized that actually people tend to become famous as artists, at least after they're dead. So that doesn't sound like the most useful way to make money when I'm alive.
Okay.
And then I thought going towards IT, and then the IT teacher said, Gyles, there won't be any jobs, which obviously was the biggest load of nonsense. But at the time, in the just turn of the millennium, people weren't always aware of just how big a move to, well, actually, I think they did know. The IT teachers were probably just a bit stupid. But anyway, I was heavily discouraged from going into IT. And then I thought, well, what am I going to do with my life? I was about 14 at the time. I thought, let's go into medicine. Let's go and be a doctor. And because it's a great opportunity to still use my desire, my need to help people.
Yes.
I'm very much a person that sees how can I make the lives of someone else better. But then also I was very interested in science and particularly biology. How can I bring that all together in a career where I might be able to travel, could still have a good salary? And then, working as a doctor just came to me. First doctor in the family, which was really a wonderful moment, actually graduating. Thank you. And then, but I realized that medicine wasn't quite cutting it for me. I worked as a doctor for 3 years. And very quickly in my first year, I realized that the work-life balance, the ability to actually really bring change in people's lives. Like obviously, if you save someone's life, they've just been, their heart stopped. You revive them, help bring babies into the world. You deal with someone who was near the brink of death, but you've been able to treat them and get them better. This is a wonderful thing, and I was honored to work as a doctor. But I thought there's so much more about the problems that I simply couldn't solve as a doctor, that I realized I need to do something a little bit different. And I still had so much interest in IT and in graphic design, visual design, that when I realized that I could do something in digital health, I jumped at the chance. At the time, I had never heard of user experience, or UX for short. But since September of 2014, I've been carving out a career now in what I've defined as clinical UX. So if UX is about the design and the experiences that people have with anything that's been designed, healthcare UX would be about the experiences people have with healthcare technology and services. And clinical UX would look at the experiences clinicians and patients have with healthcare technology and services. So that's been my niche. After working as a doctor for 3 years, looking at how do we make healthcare technology and services easy to use, accessible, and even fun, if not at least satisfying.
Exactly.
And yeah, so my career over the last nearly 6 years now to this point has taken me now to Germany. And I have been able to work on projects internationally. And I would say the problems that I'm still seeing here in Germany are ones that you would find in most of the so-called developed world. There's still health inequalities that are prevalent because of race and socioeconomic status. Mm-hmm. So there's still a lot of work that needs to be done in this regard. I think even just the application of user experience in healthcare is really, really low. Like, it's just poorly understood. Exactly. So when you think about you want to use Netflix, or you want to play a computer game, or you want to transfer money using your banking app, most of the time you're going to have a great experience, as in like you should be able to use it, interact with it, whether you're blind or deaf. So disability isn't necessarily holding you back. Being elderly shouldn't stop you from using Netflix, transferring money from one bank account to another on a mobile phone. Again, you see elderly people even playing Fortnite and all these other modern computer games. But there's something about using an app to improve your health consistently, like as a mainstream thing, we're still not there. There's loads of health apps on the market, and many of them are actually quite poor in their design, and worse, can actually harm your health. I'm sure yourself, Douglas, you've probably heard about, apps specifically in the mental health space, which you've got experience with from your career. There's loads of apps trying to say, use this app, it's going to cure you of anxiety, of depression. And they've never been validated. They don't have, clinicians who have used them to say that, yes, this is correct. This is something that we can stand by as an appropriate tool to use. And this is a big problem. We're not taking the design of technology that is user-centered seriously. We're not considering the actual different people who are affected by healthcare technology and services from a digital perspective. We're not taking it seriously. Yeah. And until we do that, we're going to continue spending billions, hundreds of billions of dollars on digital solutions in healthcare that are making money but not changing lives.
On that note, I salute you for being able to articulate that challenge that we have in the health space. Unlike any other sector, I believe health is one whereby the user experience has been completely neglected, and to its demise, as a Chief Clinical Information Officer, Digital Transformation Lead, whatever role I'm doing at the time, I can testify to that whole mindset, and I'll put it down to three things, like the triple C, in terms of like when we implement technology within the health space. Very often, the design of the solution is done in a very sterile environment, very clinically free environment. Yeah, it's not in the clinical environment. I'm basically trying to say it's in an office environment, right? Away from the patients. It's in a lab. Yeah, that's right. It's in a lab. Let's be clear. It's in a lab, and in that lab environment, they set up different scenarios, different use cases on how it can be used within practice. But when the project is initiated, there's not enough clinical involvement. So when I say triple C, I always look at things such as conscious. They're like, I don't believe technology companies as a whole are very conscious and are awake to the needs of the people using their solutions.
That's right. That's right.
And they don't have contact enough with those clinicians and those patients that have to engage with their solution. And because there are poor contact, was it conscious contact? Yeah, right. So because those two fields are very much lacking, yeah, and also concrete. So the last C is concrete. So you can have contact, i.e. superficial, and I've seen many times whereby we get a clinician involved in a project, and once you've rolled out a module, whatever the case may be, they go about their business. Their services are no longer required. Is that the same experience that you're having in Germany in your experience?
In Germany, in the UK, in the US, in South Africa, in South America, it doesn't matter. This happens time and time again. And it's really disappointing because what you've done is you've said to someone, what would you love to have? And they've given you a shopping list of what they want, okay? But they're not doing the shopping themselves, you know? They don't even know how much it's going to cost, what is the, you know, how heavy it's going to be. They don't even know how you're supposed to transport this shopping back to them. All they're saying to you is what they want. You know, people tend to be experts on what they want, but they're not experts on what they need. And this is the biggest problem of just getting a consultant or some other doctor to come on board. And this is the thing, it's even this view that a consultant or a doctor is enough to create a solution for nurses, for physiotherapists, for the general public. Like, why is it just seeing these very specific professional is in isolation going to be enough? So that's the first problem. And then you're not really trying to test out the solutions with them once you've come up with an idea. You're assuming that because you've consulted them and they've given you what they want, a list of, you know, requests, rather than you fully evaluating what they need, you then just give it to them and like, well, this is what you said you wanted. Wonderful. And the truth is you wouldn't do this in any other context. Like if you go to McDonald's and you say you want a Happy Meal, you know what a Happy Meal is going to entail. There's a wonderful picture when you go into the place that shows you even the toilet you're going to get this week. But if you go into McDonald's and say, I want a piece of jerk chicken and rice and peas, maybe a slice of, you know, side of coleslaw, of course they're not going to give you exactly what you want. Why? Because that's not what they've got expertise in. You can make your requests, but if you're not going to someone who even knows how to deliver on what you want because they truly understand you, you'll have a mistake. That's why I use that as an example. If you went into a Caribbean restaurant and asked for that, even if it wasn't on the menu, you should already believe that they could help you. So some of that dialogue has helped. So this is a situation where you as a clinician goes to a digital healthcare provider who's going to create a digital solution, and they give you something that, you know, they should have some idea because they've got clinicians on their team. But what's missing then is who is actually ensuring that we're really giving what's needed. Like anybody can make a website for doctors and that website is made by doctors themselves. It's how are you testing out that the solution really satisfies a need? This is what UX is about. It's about, and this whole concept of design thinking is about understanding how can we have a mindset and a process that ensures that we provide the best solution, the right solution to the right problem. And this is a process. It's not a quick thing. You know, it doesn't just come from speaking to one person and then just telling you what they want. It's even understanding what their needs are. And then through exploration, through testing, through ideation, through creating and being, you know, really inspired by what's already around you, then you come up with potential solutions that once tested and have been iterated, deliver on needs.
Exactly. I totally agree with you there. Too often we get the token clinician on board to be the safety officer, to sign off parts of the project, not understanding the needs of the clinician themselves, because the clinicians have to maintain a registration. And I was seeing some software companies where you have retired clinicians offering real-time, up-to-date solutions when they're so far removed to what's happening at the coalface. Then there's also challenges in the sense of, okay, if you want a clinician to maintain their registration and also provide value in your software company, there has to be that flexion. There has to be that flexibility to understand that by enabling this person, this individual to straddle the two parts, they're going to need time. They're going to need a bit more supervision than normal because the clinical environment is not like any other environment on earth. In any other, and you can work in technology and go across different companies in technology. They're pretty much the same. Mm-hmm. The questions you're going to ask, where are the toilets? What time's your break? Where's my desk? It's pretty much the same. But any clinician, whether you work in mental health, the acute sector, we're dealing with human beings. We're dealing with issues that sometimes we're wrestling to reconcile when we're back in the office and then drawing flow diagrams and explaining why software best works in this way. And I don't think there's that recognition. There's sometimes there's that competition whereby non-clinicians might feel, wrongfully so, that their skills are being undermined when a clinician walks into the room. And then it's that competitive nature where you don't know coding, right? You just know how to treat patients. But I think there needs to be a lot more harmony in it and respect for both each other's skill sets. And you come together with a unified view to help somebody address a need. Yes. You know, that's me going on a soapbox. So I've seen it so many times. So the user experience in the UK, I know you know Tower Hamlets, East London and all that. Where the way we measure quality in health is normally measured on 3 metrics, broad metrics, patient safety first, productivity and efficiency, they're normally combined, and then user experience, But in your experience, have you seen software companies really sincerely go after user feedback?
Yes. In healthcare, not enough. Definitely not enough. I find that in general, we do see many companies take this seriously. Like a good example would be any game producing company worth its salt will take it seriously. In fact, there has been games that have literally been made from feedback. Like it's not just that a game was iterated and made better, but I mean, a new game that's come out is literally from direct feedback from a previous game. I've seen this happen. When you look at healthcare, the main time that you perhaps get feedback, specifically looking at user experience involving technology. So we're saying that not just can we get feedback on whether we have treated your cancer very well, like the NHS and most hospitals, they're quite good in trying to get patient experience feedback. But when we're talking about UX feedback on a digital product, it's terrible. When you see it being done well, it's a few startups who, in order to get investment, they're incentivized to get feedback from their users so they have wonderful quotes that they can present to investors. And of course, there are also some that do take it a little bit more seriously, that, you know, you want to get true sentiment from your users. So it really does help you with your quality improvement of your product. But for sure, it's not common practice. It's not standard practice. It's not the norm at the moment, unfortunately.
And I again, there's a lot of synergy here because I totally agree. And when they do sometimes ask for feedback, it is steered. Then they're not prepared for the harsh feedback. So you have a questionnaire that Socratically steers people to a conclusion that the software is still good.
Yes, you know? That's right. I think what's really bad with this, I've had examples from some of my colleagues who've started out in healthcare UX, and they've done research for a client. The client themselves, the main contact is a consultant physician, okay? And so you've literally got recordings from patients who are saying that this is a great idea, but it doesn't work for me. Like, I'm not going to use it. I don't want it. Like, they've literally said those words.
Yes.
And then the clinician has literally said, I don't believe it. Like, as in, like, I literally don't believe it. I don't accept this video recording that you're showing to me. And this is a really terrible bias. The fact that, you know, even in the face of blatant evidence, you are refusing to accept the fact. That's what you call a delusion. That's actually like a recognized medical symptom of someone who is suffering illness right now. And we're talking about, you know, supposed to be a sane, competent clinician who's like, you know what? I don't believe the evidence that you're presenting to me. And in any other context, you would call this out as absolute insanity. Like, if you are a doctor and you see a patient and, you know, they've got a knife in their back and they're not breathing and they're bleeding out, and then you say, this patient is absolutely fine. If anybody was to say that, you would say that they're insane.
Oh my God,
and to me, that's the exact same thing that's happening in digital health.
Yeah.
You're being told and you're being seeing clear evidence of a problem, right? Feedback coming saying this is not acceptable, and you're saying, you know what, it's absolutely fine. And the reason behind this is an agenda. Someone's got an agenda that they just want to have what they believe is right to just happen. Or worse, they're going to get paid a lot of money to allow this incompetence, this poor level of quality to exist. Like, we've got to call it out for what it is, that this happens too often. You know, this belief that we can just allow bad things to exist.
Yeah. Yeah. And it's prevalent within health. Unlike, say, for example, the motor industry, cars in the thousands can be recalled. In the thousands. Toyota has no problem in recalling thousands of its vehicles. Ford, same thing. Renault, the same thing. BMW, the same thing. When a fault is found within a vehicle, they can recall that. Even if you look at your domestic appliances, such as your Zanussi, your Hot Points, they recall washing machines all the time. You know, at their own cost, you know, and it does go into the millions. However, within software, what tends to happen is workarounds.
Yes.
That's what tends to happen. Do you know what? Okay, we understand we're going to fix it in another release the next couple of years. But in the meantime, change request. In the meantime, what we do suggest is you work in this protected way to make the system fit your workflow. That in itself introduces clinical risks. And as a clinical safety officer, I really, really drum home this message that it is far safer for clinical processes to support at the NHS or any health organization redefine the clinical processes. In fact, it should be part of the project plan, whereby because as you cannot say to a clinician, you will know exactly how to change your policies and procedures in line with a new piece of technology. They're not a technology company. Technology companies know the ramifications and the breadth and depth of their software when it's installed. No clinician will know that. So therefore, there needs, there's so many times a piece of software is installed, but it's not supported by the right updated protocol. So the person on the ground knows how to use it, just in the sense of they were shown in a quick training session, this is what you do. But the rationale behind it is gone. So they decide, obviously, we cut corners sometimes to meet the needs of the patient, but that corner that you cut, that pick list that you didn't select can have a knock-on effect later down the line, upstream, downstream, wherever it is, where that data is required by another clinician to make an informed decision regarding the care. So it's very, very, very important that we address it. And I'm glad that you are highlighting it, because quality is always based upon those three metrics. User experience is one of them. The patient experience and the clinical experience all the time. But I don't see a lot of sharing of that. What tends to happen is trust will typically ask the software company, can you tell me where else you've installed your software?
And that's the only measure of how good they are. And this gives rise to something that I call perceptioning. Okay, so we know what perception is something that you see, like your perspective, your viewpoint of something. But perceptioning is something that I've come up with, because it's something that I've observed over the years, and I never really had a name for it. So perceptioning is the ability of going through a process of or any sort of way of ensuring that a particular perspective is maintained without lying.
Hold on.
Okay,
Hold
guys,
on.
everybody ready?
Atomic mic drop.
Yeah. That deserves one of those. You need to say that again. Perceptioning.
Right. Perceptioning, right? This is a way of allowing a particular perception to exist, to be persistent without actually lying. And this is really, really dangerous. Like, let's take a use case of how this is actually done, right? There is a lie that's being given. For example, that this healthcare technology is definitely going to be able to create a software solution for your hospital that's going to solve XYZ problems, okay? There's this first lie that's been made, okay? And then loads of other people, they don't necessarily say that we can't make the solution. They don't call out the fact that there's a lie going on here. All that happens, though, is a variety of things that are said and done to allow that lie to persist and for things to just become a status quo. So a company will be called in, they'll be given requirements, they'll do the work, they'll deliver on the product. It's not really, what the clinicians want. They're not quite happy with it. They start suffering issues. And you know what? That company goes ahead and makes a product for somebody else. And the hospital has to still use that software for years to come. And it's all been because no one has actually said the truth about the situation. They just allowed this perception that this decision that was made was good when it was always a bad decision. And it just persists. This is perceptioning.
No, thank you for that. And I shall use that. Look out for it in a LinkedIn quote soon. Right now, it's important. I think it's very important because unlike sometimes when you're doing something wrong, it's important to stop and reflect without bias and formulate a more objective conclusion regarding software. But the contracts that a lot of health providers and social care providers are duped into signing last such a long period of time that they can't afford to be financing two pieces of software at the same time. So they end up with this mindset whereby it's just good enough. Let's just ride it out. And then the investment that clinicians have had in terms of coming up with workarounds, has deemed it more risky to embrace a new piece of technology, even if that new technology will enable them to work in a far more productive, far more efficient, and a far more clinically safe way. It's because the teams have invested negatively their time, their energy, their passion in making something work. And they rather stick with the devil they know than something that they don't know. And I think that is wrong. And I think we are doing the general public a great disservice whereby we are not enabling them to get better quicker. We are still having the same issues in terms of referrals coming in and incorrect referrals coming in. Patients staying on wards longer than they should do because of the freedom of movement of data isn't as seamless as it is across different services. Data sharing agreements do come into play here, but outside of that, the technology, I would say, is greatly impacting on our ability. Like when I qualified in 2003 as a nurse, mental health nurse, 2003, and I could quite honestly say all the practices that I was trained in are still in place today, from the ward round to the handover. Exactly.
Things haven't changed. Yeah.
Exactly. And if you go back to, what's that Michael Douglas film, One Bird Flew Over the Cuckoo's Nest, 1970 something. Nurse Ratchet is a metaphor for the way patients still are administered medication to this very day on wards, despite the technology. So that something's happening there. All those pieces of technology were brought in with a use case. Yeah? That went from as-is to a to-be situation.
Yeah.
But they're still working as is.
Yes. And I think a big reason for this, right, is that despite clinicians, doctors, nurses, physios, any area of professional providing clinical care, they are problem solvers, okay? They're people who, when they throw lemons, they make lemonade, they make lemon meringue pie, they even make the lemon vodka shots. Like, they don't mess around. They will find a way, right, to succeed so that patients can have the best that they can. But they also are given really, really rubbish conditions to work within. You're being told to make that lemonade, make that lemon meringue pie, make those lemon vodka shots in a kitchen that is dirty, that is small, that is crammed, where you don't have enough glasses, shot glasses, the oven is half working. Like, the conditions that you're having to work within, the constraints that you have as a clinician, even in the most souped up of hospitals, is still poor. And then you throw in these software solutions that are being forced on you, that you're not being included in to design. And it makes it very, very difficult for clinicians to thrive and really do all that they can to do what's best for their patients. And even in this time of COVID-19, it's completely unacceptable. Like, let's just call it for what it is. It's absolutely abomination that clinicians don't have PPE. And you are literally putting your life on the line to look after a patient who's got an infection that could potentially kill you. You're not a soldier. You're a doctor. You're a nurse. You're a healthcare professional, right? You should not be dying in the service of trying to treat a patient. It's not a war zone. It's a hospital.
Yeah.
But these are the sort of issues, is that you've got really talented, really capable people, but I would say the power structure that's in place is not really doing what's best for both the patients as well as the clinicians that are serving those patients. It's heartbreaking. It's
totally heartbreaking. And I remember providing direct care to a young lad who was about to be discharged, and we were looking at onward referral services for him in the community so he can go and do some more therapy. And so I'm at the bedside. This was only a couple of years ago. I'm at the bedside, and I don't have the technology for me to find out locally what's available.
Yeah,
I'm the clinician there. I understand the role of the clinician is evolving. So technology is supposed to make me more a signposter, a more giver of information, so that the patient, the individual, can take better control of their own life, make more informed decisions. So at that point there, when I'm trying to impact information that this young person can go and engage with by themselves in the community, I was left adrift. I had nothing. This is what happened. The young chap's mother came, and she had Google on her mobile phone. And she told me what services were available in the community for this young chap. She told me, the mother told me. I then took that information and I wrote it, and left it in the nursing office, the number of the organization, and the name and the number of the organization. So other nurses, if they're in the same situation, they know there's a service out there that provides this therapy out there. But I'm the one that done the training. It's such a role reversal when a patient is coming to hospital with better technology than the care provider. it's the irony in that. How does that happen?
Yeah, it's ultimately happened because, as highlighted before, there's problems to be solved. The clinicians are problem solvers, but so are parents. Like, parents, particularly mothers, man, they are serious problem solvers. If their child has got a problem, they're going to make sure that child gets better, and they will put their life on the line to do so. And this is the problem, is that, as much as we should have people take responsibility for their care themselves, at the moment, the current way that healthcare is provided is in a very maternal, parental, paternal type of way, that you must go to a doctor or another sort of experienced senior healthcare professional in any discipline in order to get the healthcare knowledge and treatment that you need on a routine basis. There's this expectation that if you need a prescription for a cough, you must see a doctor first, rather than, for example, going to a pharmacist who could perhaps have enough minimal training to listen with, a stethoscope, find out, take a simple history and actually give the medication themselves, a pharmacist doing it. Like, this is the sort of ways we could be moving forward. We could even be moving even ahead of that and being like, well, you've got a history of having recurrent infections. You've got this underlying disease. You've put this information into a clinical, verified digital app. That then triggers an automatic digital prescription to give you the treatment that you need. This is where technology can be helping, rather than actually having to get the patients and, other people in the general public having to step in and provide this gap of knowledge that the clinicians can't even provide for themselves.
Yeah.
Like, it's not, again, this is an abomination in my opinion, because it's not like there isn't money in digital health. Like, this is a multi-billion-dollar business, like seriously multi-billion-dollar business in the hundreds of billions. Serious money can be made here, but the way the money is being diverted is not ultimately looking at how do we make the health and well-being of the general public better. That's what should be your main mindset. Like, what can I do to learn about the situations people are having so I can really help them?
Yeah, that's so true. And the coronavirus, I guess, has brought that to the table. How brutally, how brutally frank and honest your appraisal is, because right now across the globe, clinicians are being supported by local heroes. They're the ones that understand the infrastructure, the conditions on the ground in the communities. They're the ones knocking on the door, enabling people to have access to food, despite, the distance they have to keep and all of that kind of stuff, those restrictions. However, it's people on the ground who are not clinicians that are enabling their healthcare, particularly in the UK, to even survive and reach out to lots of people. And why is that? Because they've got years of lack of investment. And when they do invest, they invest in the wrong way. It should be incumbent on any software house to iterate their software in a timely way. Iterate in a timely way. Apple do it all the time. It almost compels you. You got to update your software because, a security breach has been identified, whatever, this patch will sort it out. Boom, you're away. Yeah. But in health, they get away with, again, repeating with, okay, we're going to put that in the next release in the next couple of years or 18 months. And until then, you work out what's best, and we'll find a solution for you in due course. That is not, and they're making enough money to change. That's the whole thing. They're making a lot of money. It's not as if they have to really invest. Building technology has never been cheaper. It's never, ever been cheaper. The things that are expensive, we know, is like building HS2, trains, our new train lines, new cities. These are costs that literally remain constant because it requires manpower, engineering, electricians, all of these big ticket stuff. But software has never been cheaper to produce.
Yeah, no, you're right.
But the costs are still skyrocketing. People asking for, a simple solution, but they're expecting the trust to part with 6 figures. Yeah. How?
It's because they're looking at their pension rather than the value to patients.
Yeah.
That's it.
Needs more sincerity out there. I think that's what needs to happen. We need a lot more sincerity. So, this is a very passionate debate, as you can tell from me and Gyles as we were talking about this, because we really feel passionate about improving the lives and experiences of patients. And our job is to make our job redundant. Our job is to make sure the patient doesn't need us. Right. That's our job. Right. For the second we engage with them, we are literally turkeys voting for Christmas. We don't want patients to be relying on us, but the technology is supporting a mindset that keeps them reliant on us and us on them. Because for me to do my job, I need to be hand and side by side with the patient to really find out what's happening, to get those blood pressure readings into context. I have to be literally physically next to you the whole day to see how it's going up and down. Oh, instead of you having physical health monitoring apps and all that kind of stuff, that's taking that stuff in a way that is seamless. Because I know, I was saying this to my colleague the other day, if you take my blood pressure at any given point in time, depending on the environment, it'll go up or down. If you do my blood pressure when I'm in the dentist chair, it's going to shoot.
Be high.
It's going to shoot. So to get the contextual blood pressure reading, you've got to have something that's monitoring me seamlessly without me even knowing. Then you can monitor trends and all of that kind of stuff. We're still not even there yet.
No, we're not. And you raise a really good point of the fact that we have become very, very good and sophisticated at collecting data, but data out of context is useless. It's like understanding, someone tells a joke and you hear the last sentence of it. It's like there was an actually amazing, great joke. But unless you heard it from beginning to end, it's a terrible joke.
Yeah.
Only because of context. Like there's a bit of it that you haven't got all of the information. And this happens time and again in healthcare. There's this always, for example, even like, AI can do all this wonderful stuff when we've got all this big data. And it's like, have you really gone through a design thinking process? Have you really looked from a people-centered design process? What is the real problem that someone has so that you can identify the right solution to it? And it always comes back to this, that people are not being driven by necessarily, what is the real problems that are people having, and then finding solutions to that. Is too much about profits. It's too much about perceptioning.
Yeah, perceptioning. Too much about
maintaining your pension.
Yeah. I think you're right. And AI is one of the bastions, one of the hurdles humanity has to come to terms with. All of humanity has to come to terms with it. And it's one of those ones whereby I feel, and I've had a conversation with some of my peers about this before, mankind has the opportunity to improve on how it treats each other, based upon race, ability, disabilities, genders, all of that. It has the ability through AI to completely revolutionize and get rid of racism, sexism. It has that ability. However, what you find is in AI conversations, they're not having conversations about race. They assume it does not exist. Only when enough people cry that if I'm typing black man in Google, they want to do something about it. But inherently, the people doing the coding that create the AI, because maybe stereotypically they're introverted, they're not worldly people. They don't they don't have that experience of Africa, Asia,
or female. Even people from Africa or from the Caribbean. Like you will have obviously African and Caribbean developers, but specifically time and time again working on these projects, is it people that are truly diverse? It isn't. Exactly.
And there needs to be, I think, controls in place right now to ensure that when AI really kicks off, because I think we're still at the launch phase of AI. But
I agree.
When we get to the point whereby that data means something, without these controls in place to make sure that there's no bias put in. Because the whole point of AI is to remove bias. And we know as human beings, we have an unconscious bias anyway. We do. Yes. We have it. AI is not supposed to have it. Yeah. That's the whole point. But we're finding that AI still has the bias because it's still essentially being coded by human beings. So we're just putting forward into the future the same issues that we had pre-AI. So I'm really passionate about, anyone with a voice, anyone with a platform really needs to start exploring AI, to ensure that conversations come about whereby it is embraced for what what it should be, which is a savior for humanity, a true liberator. Because with AI, you should be able to create new ways of working that will actually free up your time to spend more quality time, not to lock up more people because of based upon people's grandparents' stories they told their grandchild that they put in code, to know that this person's a threat. That cannot be the case. So, we could talk all day, but you know what? I was going to ask you again. You do so much. And as I look on your profile, I have to salute you. Out of all of this stuff, doctor, doing behavioral change, supporting clinicians, and also take a look at the patient experience as well. You also do guest speaking, international speaker. Yeah?
Yes.
How did you get into that?
So my first international speaking opportunity came from a good friend of mine, Theo Saul. So he's a conference organizer based in South Africa. He does a lot of conferences around UX and Java and PHP, things like that, for developers.
Okay.
And he reached out to me. I feel like it was in August of 2016. He reached out to me. He's like, Gyles, would you be interested in being a part of a healthcare UX conference in a couple of years from now? It's like, yeah, sure, I'll be interested. I have no idea what I'm going to be doing in a couple of years, but yeah, of course. And so I then asked him, are you doing any other conferences? And he said, yes, I've got one happening in South Africa in November. And it says, do you have any speaking slots still available? And he said, yeah, we do have one left. So I thought, all right, then this is a time where, because I'm just starting out, I thought I'll buy my own ticket, but he'll find accommodation and stuff for me. And I got there. He gave me a keynote speaking slot, which was incredible. For the first day, I opened the conference with a great talk, looking at user experience, specifically in the confines of healthcare. It was a more general UX, so applying UX to any industry conference. But I focused on a healthcare perspective and my journey in getting into UX. And that was wonderful. And since November 2016, I've not looked back since. I now continue to do conferences sometimes in South Africa, in the United Kingdom, Netherlands, here in Germany and other parts of the world. And I think it's important to speak at conferences. Obviously, it's nice to travel around the world, but it's being able to share knowledge. As they say, knowledge is power. And there is a unique power that comes from understanding what UX can actually do in healthcare. And so I do take pride in being part of the solution that we need in the world, which is getting more healthcare professionals as well as designers working together to improve healthcare UX.
Brilliant.
And there's an increasing number of healthcare professionals now who are looking at how can I learn about UX so that I can have a dual role as a clinician, particularly as a doctor, a nurse, and a physiotherapist. I tend to come across, how can I continue working as a clinician in those areas and work in digital health, help with the research and the design of new digital solutions. I'm glad to be a part of a movement that can bring about that change. So I do that through the Clinical UX Association, CUXA. You can find out more information from clinicalux.org.
Brilliant. And also, if you want to get hold of Dr. Gyles Morrison, I'm sure he'll share his information in the show notes as well. So
yeah, of course.
Yeah, so
just check me out, drgylesmorrison.com. You can find me as well, Dr. Gyles Morrison on LinkedIn. You can find me on Twitter. And I'm happy to hear from you.
Yeah, let's continue to engage with this conversation. And anyone that's heard the conversation, if you feel passionate enough, if the conversation moved you or compelled you to get off your seat or say, these guys are talking rubbish, I want my say in this. Fine, come on, let's have this debate, because what we try and do here, as Dr. Gyles quite rightly said, is move things forward. We're here to provide value. We want to really empower the patient, and we want to really vote for ourselves out of a job and do something more exciting, but however, whilst there's a need for us, let's make sure that we fulfill that need in the most productive and most efficient way possible. So that is improving the quality of care, not just productivity, efficiency. User experience is a very essential part of that triangle piece, the holy trinity to improve quality. Gyles, thank you very much for being on the Mic Drop Club. We'll catch up soon.
Definitely. It's been a pleasure.
Fantastic. Take care.
Thank you for listening. Don't forget to check out micdropclub.com and get the show notes and useful links. Subscribe to the podcast. Don't just live life. Make life boom.